Okay, I think Dr. Webben will not be able to join us. He has some issues. His father is sick. I hope he is get well very soon. So I think I guess we can start. Dr. Muhammad, what do you think? Should we start now? Dr. Muhammad, do you hear me? Dr. Muhammad, can you hear me? Dr. Muhammad, you hear my voice or no?
Ahmad, I am not able to listen to you. Your voice is too low.
I will.
So everybody waiting. We will take a few minutes more. We are waiting for
Dr. Webben,
Vipin.
Dr. Muhammad, can you hear me now? I don't think so. Dr. Muhammad, can you hear me? Can you hear me, Dr. Muhammad?
Hello.
Yes, I'm sorry, I have some connection issues, so my voice is not very clear. Dr.
It's a
Webben
bit.
will not be able to join us, unfortunately. So I think we should start. What do you think?
Should we start?
Okay, I will start welcoming the audience and welcoming you, and you can start, okay? So welcome everyone to the 13th webinar of the Comprehensive Neuroanatomy Educational Program organized by the Yemeni Neurosurgical Society in collaboration with the WFNS World Federation of Neurosurgery, Young Neurosurgery Forum, and Pakistan Society of Neurosurgery, and Neurosurgery Coach, and Neurosurgical TV. Today, we have Dr. Muhammad Nawaz Khan, an associate professor.
Yes,
And
Ahmad, I'm sharing the
head of
screen.
neurosurgery and spine. Okay. At Lady Reading Hospital, Peshawar, Pakistan.
Yeah.
We will talk about anatomy of the seventh cranial nerve. Dr. Muhammad, thank you for participating with us. Please, you can start.
Thank you, Ahmed. Am I loud enough? Everybody can listen me?
Yes, your voice is very clear.
Okay, so good evening, everybody. Today we are going to discuss 7th and 8th cranial nerve, of course, for neurosurgeons. And we will be discussing the anatomy, a brief overview of the gross anatomy and the microsurgical anatomy, then the radiological anatomy, and the new term which I have written here is neurosurgical anatomy, by which I mean I will be discussing the neurosurgical pathologies of the 7th and 8th cranial nerve and the various approaches which we adopt for dealing these 7th, 8th cranial nerve pathologies. So we will be a bit brief at gross and more detailed at microsurgical and radiological and neurosurgical anatomy, so that if we make it more interesting and useful. As I have said already, gross anatomy, microsurgical anatomy, radiological anatomy, and 7th and 8th nerve neurosurgical concerns will be discussed. First, we will briefly discuss the facial nerve. As you know, facial nerve is actually the nerve for the facial animation, with some of its function related to secretomotor and some sensory function and taste to the anterior part of the tongue. As you can see in the diagram here, let me activate that bit. Okay, I have to. As you can see here, we have 7 nerve nuclei, in which we have this first major facial nucleus. You can see it's a motor part of the nucleus which supply the muscles of the facial expression, the posterior belly of the digastric muscle, the styloid muscle, and stapedius muscle. And but you can appreciate the fibers of this facial muscle go behind and make a loop around the 4th cranial nerve nucleus and then come forward. It has a clinical significance which we will be discussing later. We have another nucleus of superior salivary nucleus here, and the spinal trigeminal nucleus, a part of it is involved in facial nerve, and another nucleus is the solitary nucleus, which is also involved in the taste of the anterior 2/3 sensations. So this diagram is very helpful, and it shows like this facial nerve arises from pons and medulla junction, and it is about 0.5 to 1.5 millimeter in diameter, and it travels very close to the vestibulocochlear nerve. It just looks like a single nerve by naked eye, and it travels into the this CP angle and enters into this. You can see the internal auditory canal. From there, it enters into the auditory canal and along the side of the internal auditory canal, and then through inner ear and the middle ear. It takes a sharp turn here, as you can see, making a genu. And this genu is actually the geniculate ganglion. You can see here labeled as geniculate ganglion. And from there, the geniculate ganglion gives off a branch here, which I will be discussing later. But after taking this turn, the nerve curves back here and enter into the facial canal and take an exit at stylomastoid foramen, which is behind the ear and in between this mastoid of process of the skull. So basically, facial nerve gives off total 3 nerves, the 3 branches within the petrous part of the temporal bone, in which the first and major one is this one, the greater petrosal nerve. This is the greater petrosal nerve. The greater petrosal nerve moves forward and it joins this pterygoparietal ganglion and gives supply to the eyes and the lacrimal glands of the eyes and the nose, lacrimal and some of the salivary glands of the palate. So these are basically secretomotor fibers which are being given through this greater petrosal nerve. The second branch, which is being which arises within the petrous part of temporal bone of the facial nerve, is the nerve to the stapedius muscle, which is a small branch, and is that's its importance is like when we have a patient with a Bell's palsy, so he also complains of some problem in his hearing. It's just because of this stapedius branch of the facial nerve, which gives some dysfunction to the hearing of the patient. The third nerve, which arises within the petrous part of the temporal bone, is this chorda tympani. So the chorda tympani branch, it gives some secretomotor fibers. Also, the anterior third of the tongue, it gives taste fibers. So these three branches are arising within the temporal bone and not visible outside the bone. But as the nerve emits and come out of this stellomastid foramen, you can see this nerve, which is the retroauricular branch. And this retroauricular branch gives supply to this rudimentary muscle, which is more active in primates, involved in movement of the ears, but it's not possible in the human. And it also supplies the back of the ear, like the pinna, and behind the skin behind the like this ear. It also supplies the external auditory canal as well. It also this branch gives one small rudimentary branch to posterior belly of the digastric muscle and omohyoid muscle. After it, the muscle, the nerve emerges, it moves forward to the angle of the mouth and it enters into the parotid gland and divides the parotid gland into two, the superficial part and the deeper part. And there it gives 5 branches. As you can see, this first branch is the zygomatic branch. The second one is this temporal branch. And the third one is the buccal branch. And fourth one is this marginal mandibular branch. And the fifth one is cervical branch. So totally this facial nerve gives 3 in the intrapetrosal branches, 1 at the exit branch, and 5 terminal branches. So this is all about the gross anatomy of the facial nerve. As you can see here, this is the cross-sectional anatomy of the pons. You can see it's a pons. These are peduncles on the sides, and it's the 4th ventricle, you can see. So I want to show this facial nerve nucleus, which gives off fibers, as I had shown you in the previous image. They curve back and they take a turn around this 4th nerve nucleus, abducent nucleus. And it makes a bulge inside the floor of the 4th ventricle. This is the 4th ventricle, this bulge here, which is called facial colliculi. So the importance of this is that if stroke, tumor, or during surgical resection of the posterior fossa, 4th ventricle tumors, if this area is damaged, so patient presents with hemifacial paralysis. Along with that, lateral gaze palsy. If you remember from your basic knowledge, this 4th nerve gives supply to the lateral rectus. So when this area is damaged, lateral rectus muscle function is gone, as well as the facial nerve, its lateral function is gone. So one side of the face will be paralyzed and lateral gaze or horizontal paralysis of the eye will happen. So this is important thing to remember. It's an important anatomical landmark. Now, you can see this is the real time. This is MRI of the patient. The pons can be visible. This is the peduncle, inferior peduncle, the fourth ventricle, and the floor of the fourth ventricle. This is the facial colliculus, the facial nerve nucleus, and the abducens nucleus. So if any damage here occur, patient will not have only one side of the face paralyzed, but also the horizontal movement of the eye will also be gone. This is a very beautiful picture. As I have discussed, the facial nerve goes along the vestibulocochlear nerve. It is so close that both nerve complexes on naked eye seems to be a single nerve. So here we are discussing vestibulocochlear nerve, but you will see the facial nerve as well in this picture. And please focus on this diagram. It is going to clarify the entire nerve complex. The vestibulocochlear nerve is composed of two nerves actually, vestibular part and the cochlear part. As all of you know, cochlear part is involved with the hearing of function, and the vestibular part is involved with the balance and vestibular function of the body. Needless to discuss here, like the vestibular nuclei here, as you can see, it has 4 nuclei. The medial vestibular nuclei, the superior vestibular nuclei, the inferior one, and the lateral one, right? And here, the cochlear nuclei are 2, anterior cochlear nuclei and the posterior cochlear nuclei. So if you focus on this diagram, this area is the pontomedullary junction, the cross section, axial section, and here is this one. This one is the petrous part of temporal bone, and it has been cut into half in axial section. You can see here the cochlear nerve and the vestibular nerve. The cochlear nerve is moving forward here to the cochlear apparatus, and the vestibular nerve moving here into the vestibular apparatus and the semicircular canals, that is the superior, lateral, and the posterior semicircular canals, right? And in the same picture, you can appreciate this one. This one is facial nerve. So the facial nerve enters via this same internal auditory canal into the petrous nerve, into the petrous apex, and it moves forward, as you can see here, like this, in between the cochlea and the vestibular apparatus, and enter into the facial canal. It comes forward here, and here it forms the geniculate ganglion. From this geniculate ganglion, as we had discussed, this greater petrosal nerve arises, and this is very important nerve, as I have already discussed, that it is a secretomotor nerve which is responsible for the lacrimation, salivation, and some part of the nasal secretions. Okay, so after giving off this branch, the facial nerve takes sharp turn, comes down, and comes out through stylomastoid foramen. I hope this diagram is nicely explaining this whole complex 7-8 nerve complex. So we will be elaborating it further in other images, but keep this whole image in mind. If anybody has any question up till this, you can ask me. Okay, we are moving to next thing. Here, I have discussed that 7-8 complex and vestibulocochlear all these three nerves pass through internal auditory canal of the petrous bone, right? So now I will be discussing a brief anatomy of the internal acoustic meatus. It is very important to note. It is not just a plain anatomy. It is not an optional thing. Every neurosurgeon must know this anatomy and must know and understand division of vestibular and cochlear nerves and the facial nerve identification, because when you are operating on a patient, you have certain procedures, you have certain pathologies in which you have to segregate, identify visibly and protect these nerves, or you have to selectively section these nerves. So it's a basic gross anatomy. Come along with me. At the end, we will be discussing those pathologies and those procedures in which you have to selectively identify these nerves. So for that, this discussion is very important. This is a internal acoustic meatus or internal auditory canal, you can say it. The whole diameter of this is 5 to 8 millimeter. It's not huge. It's a magnified view. And it has been divided into, you can see 4 openings. All these 4 openings are for the 4 divisions of the nerve. As I have already said, 7-8 complex consist of the facial nerve and vestibulocochlear nerve. And the vestibulocochlear nerve consists of the cochlear nerve and vestibular part of the nerve. And vestibular nerve is further subdivided into superior vestibular area nerve and inferior vestibular nerve. So this is the area in the 8 millimeter acoustic meatus, complete acoustic meatus, which houses the facial nerve. So facial nerve enters and at anterior part of the acoustic meatus, while the cochlear nerve is anterior and inferior part of the acoustic meatus. Superior vestibular nerve is toward the surgeon. Like we approach to these nerves via retromastoid craniectomy. So the first thing which we see from the dorsum, from behind, that is superior vestibular nerve, and below is the inferior vestibular nerve. Keep this thing in mind. This is the basic diagram, and we will be building upon our discussion on this diagram further. Here I have discussed, this is the cochlear nerve in the 8 millimeter internal acoustic meatus. This is the facial nerve, which has motor part, which is a larger part, and nervus intermedius, the sensory part, which is largely secretomotor, sensory and taste fibers. This is vestibular nerve superior part, and this is inferior vestibular nerve. Now, please focus on this diagram. This video, I have a short video. As you can see here, internal acoustic meatus, as you can see here, it houses internal, the vestibulocochlear nerve, the facial nerve, and the nerve to the internal auditory canal, that is labyrinthine artery, right? This internal acoustic meatus is housed in the petrous part of the temporal bone, which is a pyramidal bone. You can see it has this tip and the base, and it has anterior surface, the posterior surface, and it has the anterior border, and this one is the anterior border, the posterior border, and the superior border. Here you can see again the other side, internal auditory canal, which is housing the facial nerve, the vestibular nerve, and the cochlear nerve. This is the cochlea, and the nerve coming to this is the cochlear part of the nerve. This is the vestibule and semicircular canal, and this nerve coming to the vestibule is the vestibular part of the nerve. And the superior, this one which you can see here, is actually the facial nerve, which is going to enter into the facial canal. And before going into the facial canal, it is giving off a branch. So let's focus on this diagram. You can see clearly again now vestibular root, this one, the facial nerve, and the cochlear nerve, right? Here, if you focus, the facial nerve is coming straight in between the vestibular and the cochlear apparatus and coming into facial canal and coming out into the through the stylomastoid foramen. This is the right mastoid area. Here, one thing you must understand that the facial nerve is motor fibers. So the signal is coming from here to down. And the cochlear and the vestibular is a sensory nerve. And the signals are coming back from this vestibular apparatus and the cochlear apparatus through these nerves to the brainstem, right? So here I have another diagram in which the beautiful picture of the distribution of the cochlear nerve to the cochlea has been shown. Let me show you this one. This is a very beautiful diagram. Let me freeze it. Let me freeze it if I can. Okay, here you can see vestibular root coming here, and it has been supplying this vestibular apparatus, and the cochlear part, which is richly supplying this cochlea, which is a miraculous apparatus linked to hearing of, right? I think I have drawn too much lines. I have to erase it somehow. Yes, like this. Okay. Yeah, I will be using laser pointer. This part I have already discussed. The signal is coming in a facial nerve from here down there, right? And yes, the sensory signals from the vestibular and the cochlear coming back to the brainstem, to the vestibular nerve and the cochlear nerve. So now, I think we are done with the gross anatomy, and now I will be diving into the microsurgical anatomy. Microsurgical anatomy, before going into the microsurgical anatomy, I want to make concept. I have some of my residents. So I will start from the basics of the microsurgical anatomy of 7-8 nerve complex. So you won't be understanding 7-8 nerve microsurgical anatomy unless you know its vicinity, right? So 7-8 complex lies in the cerebellopontine angle. Cerebellopontine angle, as you people know it, and you should know it, that it's a pyramidal shaped area, which is a potential space in between medially the cerebellum and the pons and the parts of the brainstem, and laterally the parts of the petrous part of the temporal bone and the occipital bone behind, and superiorly by the tent, right? It's a potential narrow area. It houses the parts of the brainstem, the midbrain, the pons, and the medulla oblongata. And it has some very important nerves and arteries, which you all people might know and should remember. Like it houses the cranial nerves from 4 to 11, and it has 3 important arteries. Superior, that is the superior cerebellar artery, and the anterior and the anterior inferior cerebellar artery, and the posterior inferior cerebellar artery, the SCA, which we commonly say SCA, ICA, and PICA. Okay. To understand it easily and to memorize it easily, Professor Roden has divided this into 3 complexes. We will call it superior complex, middle complex, and inferior complex. The superior complex, each complex has one part of the brainstem and some nerves and one artery. Okay, so focus upon these three complexes. In the upper complex, we have the midbrain, and we have the fourth and fifth cranial nerve, right? And we have superior cerebellar artery. In the middle complex, we have the pons, and we have the vestibulocochlear nerve and seven cranial nerve and the nine cranial nerve. And we have anterior inferior cerebellar artery. In the lower complex, we have the medulla oblongata, we have the pica, and we have the 10th and 11th, 9th, 10th, and 11th nerve. So keep this all discussion in mind so that we move forward into the microsurgical anatomy, right? Okay, before going into the microsurgical anatomy, you must be knowing that all the microsurgical anatomy which we discuss is through a CP angle view. And in the CP angle view, we go through retromastoid suboccipital craniectomy. So patient is usually in this position, which is called park bench position. We mark our skin incision like this. We elevate the flap like this, and then we make the burr holes. I do not want to go into the details of the locations of the burr holes and details of the procedure because it's beyond the scope of this discussion. But I just want to orient you people that at which angle we are going to look at the microsurgical anatomy of the CP angle, and through this, the vestibulocochlear and facial nerve, right? So we elevate the bone flap like this and elevate the dura in this fashion toward the sinus, okay? And below that, we see this cerebellum and the cerebellopontine angle. This is the view which you people see, right? As you can see, this is the cerebellum. This is the petrous part of the temporal bone. And in between here is the cerebellopontine angle. You can see this one. This is the petrosal vein, which is a nightmare for a neurosurgeon when operating on CP angle vascular conflicts, because it's if it bleeds, it makes entire procedure a hell, right? So this is petrosal vein, and the superior most first nerve is the fifth nerve. Okay, the fourth nerve is here just below the tent, always not visible, or if you want to see, you have to direct your microscope very superiorly. And below that, this one, you can see this is 7-8 complex, and it is going laterally into the internal auditory canal. And below that, the 9th, 10th, 11th, and fibers, all that, right? So this is the microsurgical diagram of the microsurgical anatomy of the CP angle, in which you can see the 7-8 complex and the related relations. They have not shown the arteries which are present here, and we will be seeing it in next images. This other diagram, we will discuss it later. It is showing the tumor, but we are not going to discuss it right now. Okay, this all discussion, this all base of gross anatomy and the positioning of the patient and the craniotomy and the diagram was for this diagram, this picture. This is from Roten. As you can see, focus on this diagram. This is the real cadaveric fixed diagram and reconstructed diagram actually. I want you people to appreciate relations of all these nerves, because we cannot discuss 7-8 complex, this one, 7-8 complex, ignoring all this. Otherwise, it will have no meaning. So to understand and to recognize the eighth nerve, you need to identify this nerve, you need to identify this structure, you need to identify this, and you need to identify this. Only then you will be able to identify the eighth nerve. And identification of eighth nerve and seventh nerve is important for your surgical approaches, of course. So the pattern which I follow is that start from this superior petrosal vein. Okay. Okay, let me orient you. This is petrous part of the temporal bone, right? And this side is the cerebellum, in which the cerebellum has been retracted. You can see flocculus node of the this is the cerebellum part. Okay, so from this you can identify this is the cerebellar part and this is the petrous part, right? So now from this and this orientation, you can appreciate that this is the superior end and this is the inferior end. So in the superior end, you will see tent here, which is not shown here in the diagram. But you can rightly appreciate this petrosal vein. This is, I have already discussed, this is very most important structure. You should identify it. You should search after it. You should coagulate and you should cut it if you are going deeper than that. Otherwise, if it tears, it becomes a nightmare. And it has a typical inverted Y shape here in this diagram. It can be 2 or 3 or single, but typically it may be often inverted Y shape, huge vein, right? Then coming down here, the first nerve after this petrosal vein, which is deeper, is the fifth nerve. You can see this fifth nerve. The artery which is deeper and superior to the fifth nerve is called superior cerebellar artery. So if you want to identify a superior cerebellar artery or its loop, it will be deeper and or you may say anterior and superior to the fifth nerve, right? Any artery which is inferior to the trigeminal nerve will be anterior inferior superior cerebellar artery. So to identify ICA or SCA, you have to identify the fifth nerve. The artery which is deeper or anterior and superior to the fifth nerve is SCA, and the artery which is inferior and posterior to the fifth nerve is ICA, right? So the nerve which is next to the fifth nerve or the nerve which is next to the ICA is the eighth nerve. But this is not 3D diagram. This is 2D. You cannot have perception of depth. This fifth nerve is too deep and this eighth nerve is superficial. This is another identification of the eighth nerve, right? The seventh nerve, as I had already discussed with you, when we were discussing the internal artery canal, that it will be lying anterior. So when you are looking the CP angle from behind, when you are operating a patient in the routine, most common suboccipital retromastite craniotomy or craniectomy position, you will be seeing the eighth nerve. You will not be seeing the seventh nerve. The seventh nerve lies anterior to the eighth nerve, right? Okay, so this you can see the ICA looping back and coming down here. And you can see here then the ninth nerve, the flocculus, and the 10th and downwards. Now come to the right side. This is magnified view of the same picture. In the magnified view, you can see the ICA looping down here, right? And this is eighth cranial nerve. There are certain pathologies which are related to this ICA loop compressing the vestibulocochlear nerve, which I will be discussing later. So this is, all discussion is very relative. This is very practical. This is going to affect your results if you are operating on the patient. So keep these pictures in mind and we are moving forward, right? Now, as I had discussed that the pictures which I had shown were 2D. It has no depth perception, so you were unable to identify the depth of the 8th cranial nerve and the 5th cranial nerve. You could not differentiate between the two. So I have a video, if I could play it, let me check. I want to show you this video. This video will show you anatomy of the 7-8 complex, the CP angle, the orientation, and as well as the approach to 7-8 cranial nerve. As I have discussed, it's a retromystite, suboccipital craniotomy. The position I have shown you, the park bench, the incision, the craniotomy, the dura opening, everything I have shown you. Now I am showing you the short video in which you will see how we approach to CP angle for the exploration of the 8-7-8 complex. This video is basically is of the case of trigeminal neuralgia, but you can see the 8 cranial nerve in the video at one corner. So what we do, we open the dura and we retract the cerebellum to expose the potential space, the CP angle. So now you are seeing the CSF in the cerebellopontine angle, and you can see this part, which is the petrous part of the temporal bone, and this part is the tent, right? This part. You can see some pulsations here. So from there you can identify this is superior, this is medial, and this is the petrous part, and this is the tent, right? Now, after gentle retraction, you will be able to see this one is the petrosal vein, right? And you can see here the arachnoid of the CP angle, right? CP angle cistern here. We are cutting the arachnoid to open the CP angle cistern. Now you are seeing this one artery. To identify it, whether it is superior cerebellar artery or it is the ICA, you have to identify the nerves. Which nerve it is related to, whether it is superior to the trigeminal nerve or it is inferior to the trigeminal nerve. If it is inferior to the trigeminal nerve, it is ICA. And if it is superior to the trigeminal nerve, deeper or superior to the trigeminal nerve, so it will be the superior cerebellar artery, right? Now look at this view. Let me pause it. Look at this view or here. You can see petrosal vein. Here you can see trigeminal nerve. Here you can see ICA loop. And here you can see 8 nerve complex. You can appreciate the depth of vision, right? This 8 nerve complex and the facial nerve, it is superficial to this deeper trigeminal nerve. This is one identification point of the 8-7-8 complex, right? Now you can see we are draining some CSF and going deeper. There are some veins around trigeminal nerve. It was basically a case of trigeminal neuralgia. I had no video related to that exploration of the 7-8 complex. So I had to show you this video. Let me forward it if we could have some. I think it's enough for this discussion. This video is enough. Let me move forward. Okay, now this is axial section from Roten. I love this book. I love this book, and it has tremendous effort which Professor Roten has put in compiling it, and it's excellent work. Let me orient you. Please focus here. You are seeing axial section of the brain and the skull at the midbrain area, midbrain and the pons and medullary junction area, right? To orient you, focus here. You are seeing this optic nerves. You are seeing carotids, okay? The cribriform area, and from here you are coming down. You are seeing this area. This is the brainstem area, the medullary junction, right? Okay, now come here and look at this. How beautifully dissected. 7-8 complex, you can see, moving laterally into the internal auditory canal. And you can see both of them in the internal auditory canal. And if you see carefully, this is the facial nerve coming forward here and taking a sharp turn here, making geniculate ganglion, right? And from this geniculate ganglion, you can appreciate this branch is being given off. This branch, which is called greater petrosal nerve, which is a secretomotor branch and responsible for the lacrimation, salivation, okay, and some nasal secretion, right? And then you can see this facial nerve coming down into the facial canal and coming out through stylomastoid foramen. Okay, and here you can see on the opposite side the same here, the cochlear nerve coming here into the cochlear area, and the vestibular part to the vestibular apparatus. So it's a very nice dissection, very clear and excellent for understanding. I hope you people are getting it. Let me erase my markings. I was not intending to mark it, but somehow I forget. Okay, now I remember I had shown you people one diagram of the internal acoustic meatus or internal auditory canal. This is the real picture, microscopic picture of the internal auditory canal. Remember, I had told you it is 5 to 8 millimeter. It's not huge. It's only 5 to 8 millimeter. Okay. And it has been divided into 4 quadrants or 4 openings. You can see this is the facial canal, which is lying anteriorly here, anteriorly. Anterior means toward the face of the patient. And this is the posteriorly superior vestibular area toward the back of the patient, toward you, from where you are entering. What you see from here, you see first superior vestibular nerve. And this is inferior vestibular area for inferior vestibular nerve. Here you can see this area, which is the cochlear area. You can see small dots, small fenestrated area. This is called porus oticus. The name is from that this opening is not this clear-cut opening. It has multiple small holes, and the cochlear nerve divides into multiple fibers and enter into it, right? Come to this upper area. This is from Roten's anatomy, and you can see the internal auditory canal has been opened. The top of the petrous bone, the apex has been drilled off, and you can see the superior vestibular nerve, inferior vestibular nerve, this one, and the facial nerve inside the internal auditory canal. You people might be getting bored that why we are going in such details of this nerve, but I'm keep telling you each and every point is clinically relevant because this presentation is made for neurosurgeons and I have omitted all the anatomical details which are not clinical relevant, right? For example, if I ask you the most important tumor which arises from vestibular cochlear nerve is actually vestibular schwannoma, and it arises from inferior vestibular nerve, this inferior vestibular nerve, and actually inside the internal auditory canal, not outside. Okay. And initially, when Yasser Gill was doing work on that, it was his belief that the tumor arises outside the arachnoid. But now it has been proved that this tumor arises inside the arachnoid and inside the auditory canal. Okay. So some of the details which I want to elaborate, I will be building upon it in the next slides, right? So be with me, be focused. Let's move to the next slides. Here, we are done with the microsurgical anatomy. Now, as I had discussed that we will be discussing the radiological anatomy as well, because you people see MRI scans of the patients and you are asked questions about normal anatomy within this MRI scan. So if you focus on this axial cut T1 weighted image MRI of the patient, you can appreciate cerebellum, the fourth ventricle, the pons, and alongside the pons, you can see these fibers, these nerves. I think by now you people might have memorized it, that the cranial nerve 7th lies anterior to the cranial nerve 8. So by that you can differentiate and identify that this is the 7th nerve and this is the 8th nerve, right? And what is this? This is the 5th. This is the, okay. There should be trigeminal nerve, but I think this labeling is, I don't agree with that. Probably it's messed up. Okay, again, it's T2 weighted MRI, axial scan. You can see the cerebellum, you can see the fourth ventricle, the pons, and cerebellar peduncles, right? The inferior cerebellar peduncles. And you can see these nerves which are going laterally into the internal auditory canal. Here you can see, and these nerves, you can appreciate this one is the facial, this one is the vestibular cochlear. And yeah, it has been labeled here in this image. Okay. Now this image is more important. You can see 8th nerve. And what is this? ICA. And this one is the basilar artery. The ICA loop, you can see, it is touching this vestibulocochlear complex. And it has clinical relevance, clinical significance, which I will be discussing later. Okay. This view, you can see somehow, in some cases, you can see internal auditory canal into two weighted images, sagittal extreme lateral cuts. You can see the left facial nerve, okay, and the superior vestibular nerve and inferior vestibular nerve, you can see. Now, this is important for you people. You're neurosurgeons and you are expected to work on brainstem. You are expected to remove cavernomas from the brainstem. You are expected to operate posterior fossa tumors, fourth ventricle tumors, CP angle tumors. So you must be knowing and you must be aware of the tissues important structures inside the brain. As you can see, this is pons and this is cerebellopeduncle, inferior cerebellopeduncle. We have magnified it here. You can see here. Now, coming down here, focus in the anterior part of this pons. You can have the pyramidal tract. Here one pyramidal tract and other pyramidal tract, which is responsible for your motor and sensory to and fro communication from the brain to the whole of your body, right? And here, inside the peduncle, you have all the nuclei of the fifth nerve, like this one, and the eighth nerve nucleus, and again, this one is the sixth nerve nucleus. Okay, and the facial nerve fibers loop around this sixth nerve nucleus, as I had discussed earlier, to make facial colliculus or protuberance inside the fourth ventricle. Now, coming toward the pathologies, you can see, you can appreciate in these scans. This is T2 weighted axial scan, and here you can see this. What is this? Vestibular schwannoma in the internal auditory canal, which is being dilated, right? It's dilated. The same you can appreciate here and here in the contrast enhanced image. Now, as I had discussed, we will be focusing on neurosurgical pathologies of 7th and 8th cranial nerves, for which we have exercised this entire anatomy, and we have discussed this entire anatomy. And what is the practical application of this entire anatomy which we have discussed? So vestibular schwannoma, you all are aware of, arise from the, in 90% of the cases, inferior vestibular nerve part of the vestibular cochlear nerve, right? And we do microsurgical resection by the approach which I have discussed with you through pictures and through video as well, right? And we have another pathology in which somehow the patient has disabling tinnitus and vestibular paroxysmia. It might be because of the inferior ICA compression of the 8th cranial nerve. So we perform some sort of MVD procedure for that. We have sometimes intractable Meniere's vertigo, which is not responsive to any medical and conservative treatment. So we need to do vestibular neurectomy and sometimes labyrinthectomy. So to perform vestibular neurectomy, you must have a sound, exact and accurate knowledge of identifying first the vestibulocochlear complex, the 7-8 complex. And in that 7-8 complex, you must be knowing that where is the 8th nerve complex. And in the 8th nerve complex, you must be identifying the vestibular nerve and the cochlear nerve. And then you have to transact the vestibular part of the nerve so that the patient gets his vertigo relieved and his hearing is preserved. So this is what is the importance of this lecture and this entire discussion. Okay, we have other pathology which you already aware of: CP angle meningiomas, epidermoids. Okay, we have hemifacial spasm. Hemifacial spasm occurs because of compression of the 7th cranial nerve, the facial nerve, by the offending vessel. In the majority of the cases, which artery is involved? That is anterior inferior. Which nerve? Anybody? Which artery is involved in hemifacial spasm? ICA, anterior inferior cerebellar artery, right? So we do MVD sort of procedure for that. So in all of my discussion, I stressed upon that you must be aware of CP angle, its orientation, its boundaries, its structures, its identification of 5th nerve, 7-8 complex, superior cerebellar artery, anterior inferior cerebellar artery, and the pica, so that you accurately identify these pathologies and you are able to cure the patient at some point of your career. Then we get facial schwannomas, facial nerve schwannomas, in which you have to excise the facial nerve schwannomas, and there is some people are doing grafting as well, which is a very difficult task, but they are doing it. Okay, parotid tumors we do not operate. Bell's palsy I have discussed. Bell's palsy patients have some hearing disability, transient, which I have discussed because of the nerve to the stapedius. And there is a procedure which is a decompression of this stylomastoid foramen and facial canal, right? So this is why the complex picture which I have shown you people, which was of course a bit difficult and boring, in which the nerve was going straight, making a genome, and then turning back, and then coming down in the canal and coming down. That is important for this procedure, decompression of this facial canal and this stylomastoid foramen for the Bell's palsy patients. Okay, let's move forward. Let me erase my mess. Sorry for that. Okay. Now, let's see this picture. Okay, the reason I added this picture was one of the important factors in operating on vestibular schwannomas is preservation of the facial nerve. Once again, let's recall our lecture. We have discussed that vestibular schwannoma arise from the intracanal part of the inferior vestibular nerve of the vestibulocochlear nerve, and it goes medially into the CP angle. And we have also discussed that the facial nerve lies anterior to the superior and inferior vestibular nerve. So by this, you must understand and you must expect facial nerve to be lying superior and anterior to the this vestibular schwannoma tumor. So when you are operating on vestibular schwannoma, you should be very careful while you are dissecting outside the capsule of the vestibular schwannoma, especially anterior to that. Rarely it comes inside the tumor, or it might be on the surface if you are unlucky, and if you do not have facial nerve monitor, so your patient might end up with the facial nerve palsy. But in majority of the cases, and commonly, it lies anterior to that because of the all anatomy which you people have learned up till now. Okay. Okay, this is another, probably I have taken a lot of time, but this probably is the last part of the discussion of the neurosurgical anatomy, in which I had discussed that I will be discussing the pathologies of the 7 and 8 cranial nerves, its clinical importance, and then I will be discussing some of the approaches to these pathologies of the 7th, 8th cranial nerves, or approaches to the 7th, 8th cranial nerve. In simple, the first and the most commonly employed approach for the 7th, 8th nerve complex and its related pathology is the retrosigmoid suboccipital craniotomy or craniectomy. As I have already shown you, the park bench position, the typical skin incision, the craniotomy, the dura opening. I have shown you the video. It was all about the retrosigmoid craniotomy and approach. And if I can give you a tip, what I do in these approaches, that after opening the dura, it's not a simple thing. The brain is always very aggressive, especially in the tumor cases, or if it's a young patient. So it does not give space to you that you easily go into the CP angle. So what I do, I first go into the, direct my microscope downward toward the foramen magnum, and I drain the cisterna magna. And from there, I get some CSF, and my brain becomes a bit relaxed. After that, I get some space and I retract the cerebellum and I go into the CP angle. And there, as I have shown you in the video, I drain some CSF from the CP angle cistern. After draining these two cisterns, the brain goes relaxed. The cerebellum goes away from you, and you get ample space to enter into the CP angle cistern, and the cisterns really becomes a pyramidal space in which you can work. Then what I do to orient myself that where I am, I look up, or I direct my microscope a bit upward to identify the tent. I feel the tent. Then I go along the tent a bit deeper in the petro tent corridor. I go in deeper there, and I find the petrosal vein, right? So when I identify the petrosal vein, I mostly operate on trigeminal nerve patients. So I coagulate and I cut, and after that I go deeper to the petrosal vein and I find the trigeminal nerve. From there, if I want to look at 7-8 complex, so it comes downward and superficial. If you can recap the video which I have shown you, its entire direction which I have given to you for understanding this whole anatomy and this whole area. Then there is a procedure which is called translabyrinthine. Translabyrinthine is more direct approach to the CP angle and vestibulocochlear area and the facial area, facial nerve area, but it can be employed, or it can be used in only those patients in which there is no serviceable hearing, and hearing is already gone. So you can have more direct approach to the tumor, and it has the advantage of less cerebellar retraction and less manipulation in the area, which might not be required to be manipulated to remove a small tumor in the internal auditory canal. So I have not practiced this translabyrinthine approach because it's probably too complex, because you have to save facial nerve as well, and you have to identify each and every structure, and it's a uphill task. Then we have another approach, that is the middle cranial fossa approach. Let me show you a diagram. It's becoming boring and difficult for you people to understand. Okay, let's see. This is transcochlear approach. As you can see, you can drill from here up to here. You destroy entire ear apparatus, and you have direct approach to the CP angle and the tumor, and you can remove it. It is only done in the cases in which the hearing system is already gone and there is no serviceable hearing. There's a translabyrinthine approach, and there is pre-sigmoid retrolabyrinthine approach. In pre-sigmoid retrolabyrinthine approach, I show you another slide here. Yes, here. Here we drill the bone from here up to here, we expose this, what is this? The sigmoid sinus, and we lateralize it. And we go behind this labyrinth and anterior to petrosal sinus and approach the tumor. This is subtemporal approach. The position of the patient, the key, this question mark incision and this craniotomy, and you can see the dura is lifted, and then the base of the temporal bone, the petrous part of the bone is approached, and from there to the apex, and apex is drilled, and it's a big procedure, but is favored by some surgeons. Thank you. If you have any questions, please feel free to ask.
Thank you very much, Dr. Muhammad, for this very nice presentation. If anyone have a question, please, you can ask. Dr. Pragnesh Bahati.
Ahmed, I cannot hear you.
Can you hear me now, Doctor?
Yeah, now I can hear you.
I don't know what's the problem, but I have some issue with my computer. So I use my phone for sound and my computer for video. So I hope you apologize me. Dr. Prakash Bahati, I think you have a question, please.
Can anybody talk so that I just check my system whether it's a problem with my system, my speaker, or it's issue with the Ahmed side. Anybody, please?
I see here Dr. Pragnesh. He's raising his hand, but he's not responding. So if anyone have any question, please, you can ask either in the chat or raise your hand, and I will unmute you to ask directly.
Yeah, this is.
Can you hear me, Dr.
Pragnesh
Muhammad?
Bhatt.
Is my voice clear?
Pragnesh Bhatt, he want to ask a question. Yes, sir. Do you want a question? Want to ask something?
I think maybe it's he's raising his hand, but not intentionally, I think. Okay. So I think there is no much questions in the chat, and no one of the audience have any questions, apparently. So, Dr. Muhammad, I thank you for this thorough and very comprehensive presentation. You discussed the facial nerve and the vestibular nerve in a very precise and very nice manner. So thank you very much for this amazing presentation. Dr. Muhammad, can you hear me?
Yes, Pragnesh Bhatt has corrected me. It's 6th nerve nucleus, not 4th. Yes. Yes, thank you for that. Yeah, Aika was rightly answered. Only 3. Anybody?
I don't see any questions here in the chat.
When
Maybe
there is
they're
no
sending you
questions, it means
directly.
either everything understood or nothing.
No, it's a very nice presentation. I think everything was explained very nicely and very thoroughly.
Okay, let me ask questions from my residents. We have some of my residents here. Let's see whether they were following me or they were. Okay, I have Nafis, Dr. Nafis.
Okay.
Do you hear me,
Let me
Nafis?
unmute her. Okay. Dr. Nafis, you can talk now.
Okay. There is a chat. Somebody has written, host is not allowing voice. Who is the host?
What?
If you can unmute all, please, so that we can discuss it.
Okay, I think Ahmad, please, if you can unmute everyone, or maybe you can tell me the name of the person who want to ask. I will raise his hand and I will unmute him.
Sakib want to say something probably, but he's saying I'm
Okay.
muted.
Okay, Doctor, you can stop screen sharing.
Mohammed
And anyone
Sakib.
who want to ask, just raise hand and I will unmute you.
I think we should end the session if there are no questions. Ahmed.
Okay, that's also good. So thank you everyone for attending this webinar, and thank you, Dr. Muhammad, for this nice and very fantastic presentation. And I sorry about some disturbance and issues of the connections. And also I apologize on behalf of Dr. Beben. He was not able to join us because he has some family emergency as his father was sick. So I hope he's get very well very soon, inshallah.
Yeah, thank you, Ahmed. Thank you.
So by this
Thank
we
you,
can
everybody.
conclude.
Thank you for being with us. Allah Hafiz.
Thank you. And so by this we can conclude the session and see you all, inshallah, next week, next Friday at same time. Thank you, everyone.
Thank you.